Hello, everyone. So I'm going to be talking on the topic, is fertility preserved in women with PCOS? And as I was getting ready to prepare this presentation a couple of weeks ago, I came across this article in the Indian press with a very similar title, which said, "What is the best age to plan pregnancy for a woman who has PCOS?" So I think we have a very pertinent and relevant topic that has been selected by the PCOS Society of India to talk today. And what I'm going to do is just set the stage by showing you what is the evidence that tells us that female fertility declines in the mid-30s and on towards menopause. And what you can see in this slide here is decline in the follicle number based on actually looking at pathology specimens of human ovaries and counting the primordial follicles. So right up here in the blue circles are females from block study, and this is the larger cohort where they looked at young girls from the age of 7 all the way up to 44 and saw a slight decrease in trend in terms of primordial follicle numbers. And then there are two other studies in here, the red and the green, which are more perimenopausal women about the ages of 45 and 55. And you can see that dramatic decrease in primordial follicle numbers. We also have data for fertility numbers in terms of spontaneous conceptions and what are the declines and when do they occur. And so these data come from couples and women who have attempted pregnancy over the years without the use of any contraception. And we have data from the Hutterites in the US. We have some European populations here from the 16th and 17th century, actually, and an Iranian village here in the pinkish color. And what you see in general, the trend is around the mid-30s is when the fertility rates for spontaneous conceptions in these very well-tracked cohorts also seems to decrease. And finally, what I wanted to share with you was data, which is more contemporary. This is a publication from 2002 in the UK. And what it shows us here is that couples, these are healthy couples, 782 of them, who were just pursuing natural family planning methods, so trying to get pregnant. The researchers tracked 5,860 menstrual cycles. And what I mean by that is they were actually documenting the day of ovulation and timing when intercourse occurred related to that. And what they were showing was that the highest success of pregnancy, so this is the probability of pregnancy, is in the few days prior to ovulation. But as part of this study, they also looked at different age groups, and again, supporting our hypotheses that fertility declines somewhere along the mid-30s. We can see that here is the decline, which is beautifully demonstrated in women who are trying to achieve pregnancy naturally. So with this sort of background, let's sort of talk about today's topic. Is fertility preserved in PCOS? And what are we really referring to here? Are we talking about the number of oocytes? Are we talking about a response to ovulation induction? The quality of the oocytes? So really, ultimately, what matters to our patients is the live birth rate, the pregnancy rate. And in most of this remaining part of the talk, I'm going to focus on the results in women with PCOS, more like in their mid-30s and beyond and the early 40s. That's the kind of data I have tried to look for and then summarized in today's talk. So here are, let's start with ovarian reserve testing in the PCOS population. And as this audience well knows, we can assess ovarian reserve in two ways: by doing the antral follicle counts by ultrasound, or also by measuring the serum AMH levels. So when we look at data on antral follicle counts and ovarian volumes, the study I wanted to share with you comes from the US. A PCOS center in San Francisco tracked 245 women with PCOS. And then they used the OVA study, which are women without PCOS who were also being monitored for a separate study, were used as their controls. It's a study for over an 8-year duration. And what you can see here is the follicle number per ovary has been demonstrated, and by age group. So the follicle number per ovary for PCOS about 24, 23, and then decreasing to 15 between the ages of 35 to 40. So a gradual decline. In the control population, follicle numbers are almost half, starting off about 12, and this is per ovary, and then down to 10 and 7. So clearly, even in the late 30s, there is about a twofold difference between follicle numbers in these two cohorts. And then when you look at ovarian volume, which is another way of assessing this, we find that the ovarian volumes are around 10, 10, and a slight decrease in the late 30s, 7, 6, and about 5 in the late 30s. So sort of we can conclude that towards the end of the third decade, the volumes decrease, follicle counts decrease, but remain higher in a PCOS cohort. What about AMH levels? So anti-Mullerian hormone has been around for a while now, and this is a fairly large study with over 3,000 healthy Chinese women. And between the ages of 20 and about 45, as you can see here on the x-axis, these are all comers, so not separated by PCOS, and they have drawn the trend lines for AMH levels, and these higher trend lines represent the 90th and 95th percentile for the highest AMH. And I might submit to you that this might represent our PCOS population. So they start high, and then they start tracking down somewhere in the mid-30s, and all the others follow the same sort of trend line. But as a sub-analysis, what these investigators did was they did ask the question, what about PCOS versus non-PCOS? So when we look at the same cohort and break it down by women with PCOS in the age groups, the younger age groups in their 20s, 30s, and then 36 to 40, in all the groups, those with PCOS have higher AMH levels. So what it tells us that AMH levels are higher in women with PCOS. There's evidence that it's higher in the late 30s. The question is, what about in the 40s? Do we have data for that? And some of the data has come from these population-based studies. One of them that I'm going to share with you is from Iran, where they looked at about 1,000 control patients who were age and BMI matched to 85 women with PCOS. This is a separate study ongoing in Iran where they've been looking at lipid levels and other cardiometabolic parameters, but they specifically looked at certain time points, so the T1 and the T3 time point for AMH, and found that AMH levels were higher in women with PCOS than controls at both their time points. And then when they extrapolated it out, here is the graph. So the red color circles are the women with PCOS, and the trend line here shows you that it runs higher than the green color, which are the normal controls who do not have PCOS. So even in the late 40s, it looks like the trend line is higher than the control population. And very interestingly, more mathematically projected out, what these authors were able to say is that the estimated age of menopause might be a little further out in women with PCOS at 51 compared to the 49 in their cohort. And another study from the Netherlands looking at the same question, what is the decline in AMH over time? A much smaller group, 98 women with PCOS with 41 controls, 2 time points again. And then when they extrapolated into the 40s, which is the data I'm trying to share with you, it shows the same trend that AMH tends to be higher, surely declining over time, but higher than the control population. So then, is that enough? And clearly not, because just having a high ovarian reserve does not tell us if fertility per se is prolonged. So let's look at the data in terms of live birth rates and fertility rates. And I've broken these up into 2 categories. One is groups of patients who are trying to get pregnant spontaneously and on their own. And then the second group that comes in for treatment, be it ovulation induction or ART. And the reason we would hypothesize that there may be a difference in pregnancy and live birth rates in these populations is because some of the features of PCOS, they normalize by the 4th decade of life. So for example, here is the study from a Nordic multi-center collaboration that shows you with increasing age, and they go all the way into the 40s, that the testosterone levels were initially much higher in women with PCOS, significant difference as compared to the controls. And as they come into their early fourth decade of life, there is a dramatic decrease in testosterone such that these authors did not find a significant difference between the two groups. And the same for free testosterone. So this is one of the Rotterdam criteria, tends to normalize by the fourth decade. And the same with irregular menses. So when you look at the black color, it's women with PCOS, and we see the percentage of women who have irregular menses in their early 30s, late 30s, and as they get into the 40s and 50s, most of them, albeit smaller numbers here, but the cycles tend to regulate. And here is an elegant study from Italy that has looked at about 200 women with PCOS every 5 years. And over that every 5-year period, they found that the percentage of women with ovulatory cycles increased from 52 to 85%, along with an improvement in androgens and an improvement in ovarian volume. So then we could hypothesize that this group now that's having regular menses and is ovulating perhaps is getting pregnant spontaneously. And what is that difference compared to the control population? So here we have data from a fairly large Swedish registry that has looked at 45,000 women with PCOS, 217,000 controls. And they started tracking outcomes from age 18 going up for another 26 years. And in this first graph that I have here, the red line shows the probability of fecundity in women with PCOS. And then the blue line is in the controls. And what it says is the chance of getting pregnant spontaneously or an assisted conception over time is similar in both these groups. And actually it matches out with the fact that, we say infertility rates are about 15%, and here we have about 85% who are pregnant by this time period. But the interesting question is when you ask how many of these were spontaneous conceptions. And here what we find is the graph or the line, the red line for PCOS patients is certainly lower than that for controls, suggesting that this matching up of the two lines occurred because of assisted conception. So spontaneous conception rates are lower in women with PCOS, even as they get older. And here is another graph that shows what is the chance of a second birth. And again, with PCOS, it is lower, irrespective of the fact that in general, we have shown that AMH and AFC levels are higher. And here is another study that looks at the same question from the UK. It's from the Clinical Practice Research Data Link, a longitudinal primary care research database. They have 9,000 women with PCOS and 18,000 matched controls. So if you look at the very first set of in the graph, the bars here, the first bar is women who did not have a diagnosis of PCOS. And once the diagnosis was made, after that date, their fertility rate increased. And here is a control group before and after, and they use that same index date as a reference. So the fertility rate for PCOS patients almost became equal to that of controls after the diagnosis was established. Similarly, for the next age group that they looked at, in fact, a slightly higher success rate. What's most intriguing to me was in the 35 to 44 age group. Pre-diagnoses, post-diagnoses significantly increased fertility rates, and again, higher than the control group, although they did not really, I looked in even in their supplements, did not tell us whether this was significantly different. And you might ask why? Why are they, after their diagnoses, having such a big spike in their fertility rates? And what it shows us here is that the months from the index date to an infertility consultation. So there was a great peak in the number of these patients who, after diagnoses at the 0 time point, then sought fertility care. And this is the beauty of having these longitudinal records in the UK, and one's able to exactly track what's happening with the patients. In the meantime, the control population did not really have a need to go seeking fertility care right after that index time period. So a great correlation here between seeking fertility care and a bump in the success rates or the fertility rates. Let's switch then to what about the patients who come to us for IVF? What are their success rates? And here is our paper in 2013 when we asked this question using the SART dataset. So Society for Assisted Reproductive Technology is based in the US, and it is an organization where all of us IVF centers voluntarily send our data annually, and then it's also available on the CDC website. So we looked at women with PCOS alone and women who had infertility, and that was our women who had tubal infertility, and that was our comparison group. And what I'm showing you here is for the overall cohort of 16,000 cycles, 16 oocytes, significantly higher number of oocytes retrieved, significantly higher clinical pregnancy rate, as well as live birth rate. But really what you're interested in is what happens over time. And so I have that depicted here where from the age of 20 going all the way to 45, you can see that significantly more oocytes are retrieved in the PCOS groups than the blue, which is the tubal group. Similarly, significantly higher clinical pregnancy rate, which is not significant by the time it gets up here between the 40 to 43. And then the live birth rates really start overlapping around the 40. So that advantage seems to be early on. And this is only one IVF cycle from the fresh IVF cycle. And I broke it down in more detail so that you could actually look at the numbers that yes, we have higher number of eggs retrieved right up to 40, 46. But the clinical pregnancy and the live birth rates are really not different between these age groups. So after that, there have been a couple of studies that have asked exactly the same question that we did, but they have added in the frozen transfers and looked at a cumulative success rate. So here's a paper from Canada looking at women with PCOS in their 40s, the mean age of 41. And you can see that the live birth rate for the fresh cycle was not clinically significant, but these patients had more, the PCOS patients had more eggs frozen. And so when they looked at the cumulative live birth rate, again, they're not high. These numbers are relatively low because these are patients in their 40, but still you can see that the cumulative rate is much higher for the PCOS group than the control population. And here is a much larger study asking exactly the same question. Women with PCOS, 3,000, tubal factor, 18,000. So from the first IVF cycle and then the subsequent frozen cycle, there is a significant difference in the number of eggs retrieved. So this is going by age from 20 to 27 on both sides, controls and PCOS. Significant difference in implantation rate. And I've shown you some numbers for above the age of 40. What was the difference? Significant difference in clinical pregnancy rate, difference in the live birth rate. And again, these are numbers for above 40 controls and PCOS, and then the cumulative pregnancy rate where you definitely see the significance. So what is our conclusion then? That women with PCOS do have higher AMH levels and AFC even in their early fourth decade of life. If they get to IVF, then they do have a higher oocyte yield at this time. If they have frozen embryos available, then they have a higher cumulative live birth rate in the fourth decade. And if I look only at the spontaneous pregnancy rates, then they tend to be lower than the non-PCOS population. And how are we going to counsel our patients based on this? I would not use this data to reassure patients with PCOS that they have a high AFC or a high AMH and they can delay pregnancy. On the other hand, if there are social, financial, personal reasons to delay pregnancy, all of that gets taken into consideration. On the other hand, if somebody with PCOS comes to you for ovulation induction or IVF care, then even in their early 40s, I think the data tells us that they have reasonable chances of success. And we should initiate therapy right away so that they can take advantage of their higher ovarian reserve. I'd like to conclude there and thank the PCOS Society of India for inviting me to give this talk. Congratulations on another excellent meeting that has been put together. They have an excellent track record for doing this. And then I would like to acknowledge all my partners here in Philadelphia, in the US, as well as internationally, who have helped us with our research program. Thank you.